Yeah. Hi, everyone. Yeah. Maybe after Dr. Thao presentation, I want to share my case study, and is named with parenteral nutrition with diabetes. And after this case, I want to emphasize that actually we are knowing some rule related to the nutrition for the patient, especially for the parenteral nutrition. But in clinical daily basis, I thought that we should like titrate, or we should maybe like change the strategy according to the response of the patient. And um, uh, this a case when related to the traumatic brain injury. Also, the patient have diabetes, and then this the overview. I want to get into the detail. Um, we have already know that glucose is the main metabolic fuel for the human body, especially the brain and the peripheral nerve use glucose as the main source of energy. And then maybe like because of uh, the minimum daily amount of glucose is estimated to be 100 or 120 gram per day for the patient body. But in clinical daily basis, I thought that we are often like overfeed for the patient when we are talking about the glucose, and it can lead to hyperglycemia. And but a lot of research show that if we let the patient have the condition of hyperglycemia, can lead to um, bad complications such as severe infection or organ dysfunction and even death. And my my case is talking about a 53 years old male patient. She came with us with a symptom of loss of consciousness after a motorcycle and car accident. Talking about the past medical history, he had something related to the diabetes without control. And according to his family, 2 hours before admission, the patient was involved in a motorcycle accident with a car, resulting in throwing him into the roadside of the of throw into one roadside. After receiving the first aid, and then he was maybe like being evaluated, and then he was intubated in a local health department and then transferred to our hospital. On admission, the patient is had the maybe like normal vital sign, except the heart rate is quite high. It is 120 cycle per minute. And on the Glasgow scale, we estimate that the patient had only like 8 score on Glasgow scale. The pupil was dilated on the left side, and then the exact maybe like exact uh, the size of pupil on the left side was 4 millimeter, and then the patient had a lot of scratch on the neck, the first abdominal quarter. And he had an open injury on the left lower leg. But when we measure the blood glucose is extremely high, is 21 millimole per liter. After that, we do a lot of like tests for the patient. Talking about the head CT, the patient had left epidural hematoma. The hematoma had a width of 13 millimeter, and then the middle line shift to the right, uh, uh, and the patient had brain edema. Talking about the abdominal contrast CT scan, he had intra-abdominal hemorrhagic due to the third level of liver fracture. And then there was an active bleeding from the right liver artery. Also, the patient had tibial fracture. After receiving this kind of maybe like result, and uh, we thought that this really complicated case, and then we making consultant with the surgeon, and then they thought the patient was under an surgery due to, with the neurologic doctor and also the intra-abdominal maybe like surgeon for the patient in spontaneously. And then also we give fluids and then blood for the patient. We put the patient under the mechanical ventilation. Also we give antibiotic and nutrition for the patient. After 2 days, maybe I stay in the surgery room. The patient was transferred to the intensive care units. After that we will maybe like only talking about the nutrition aspect of the treatment. And then we when the patient admitted to the ICU, the patient still unconscious. uh, it is related to the TBI, and then the patient should need to control the blood glucose respectively, restrictly. And then the patient had abdominal distension. I think that is due to the functional bowel obstruction. Also the blood glucose at that time is was 40 millimole per liter. So we think that the patient is need to control the blood glucose. Even the patient is have, but the patient still have blood glucose is quite high, and then the patient is not appropriate for the maybe like enteral nutrition. So we decided that we should treat the patient with parenteral nutrition. Um, when the patient admit to our department is on the day 2, and then the strategy for the next treatment is day 3. The patient weight was 72 kilogram, and with the level of energy is 20 kilogram per kilogram. So the total needed energy was 1040 and 400 kilocalorie. And then with the protein level of 1.5 gram per kilograms, we should give the patient more than 100 gram of protein for the patient. So we decided that we should use like a bag of olive oil nutrition for the patient with more than 110 gram of glucose, more than 50 gram of protein, and 40 gram of lipid. After that, we think that is not maybe like enough for the patient, so we add about the amino plasma 10%, 500 millimeter, and then we have more like 15 gram of protein for the patient. So the the protein required is enough for the patient. After that, this not if we are maybe like only give the olive oil and amino plasma for the patient, and the energy is not enough, so we give dextro 10% with 500 millimeter, and then the total energy were given for the patient is 140 and for 1040 400 kilocalories for the patient. So it's good enough for the patient. So we can see here, when the patient admit to our department, maybe like the electrolyte is good, the level of hemoglobin is good enough for the patient, but we can see that the blood uremic the uremia was quite high for the patient, and also the level of glucose is quite high for the patient. After receive this kind of energy, we see that the level of urea is increased and the level of glucose is out of control, right? So at the next day, we think that maybe like because of the level of protein is quite high for the patient, and then the level of dextro is quite high for the patient, and then we should maybe like cut off this kind of drug on this patient, we replace the aminoplasma and dextro by the small lipid 20% and 250 mil, and then we receive this kind of, and then we met the total required calorie for the patient. Uh, After giving this kind of drug for the patient, we see that the urea is maybe like quite high, is still high for the patient, and then the glucose is increased. So maybe after the first change for the patient, we see that the level of maybe like aminoplasma or the level of maybe like catabolic synthesize in this body is still high, and then we should decrease the level of aminoplasma is right for the patient, but the glucose is still out of control. So we should maybe like do another thing for this kind of patient, and then to lower the rate of the glucose for the patient. At the next day, we are decided that we should maybe like add insulin to this kind of patient. So we add uh, we add one maybe like unit of insulin for about for about 10 grams of glucose. So in the old email, we have 110 grams of glucose, and then we put like 11 we put 11 maybe like unit of insulin in this kind of bag, and then we trying to maybe like lower the level of glucose. Also, the patient still have like abdominal distension. We add methylchlopramide for the patient. After giving this kind of regimen, we see that maybe like the level of uremic is decreased. So the solution that we give for the patient that cut off the aminoplasma is quite good for this kind of patient. Also, we see that the level of glucose is decreased. So the solution of giving more insulin for the patient is good enough, and then the blues is get into our control, right? And then after maybe like 6 days, we start because after the day 4, we give the maybe like enteral nutrition for the patient, but it cannot tolerate. So after 6 days, we start the enteral nutrition again, and then after 10 days, the patient is like um, had a higher maybe like level of consciousness on Glasgow scale is 13 score, and then the patient will win it from the mechanical ventilation, and then the patient can tolerate with enteral nutrition. So after this progression, I think that maybe like the solution that we give for the patient is good enough. For example, we cut off the aminoplasma. We are maybe like giving more insulin and then methylchlopramide for the patient. But I still have some question about this case. The first one is why we are like why we are did we like control the blood glucose is too late for the patient. And then I searched some articles show us that the insulin the insulin should be administered when glucose is higher than 10 millimole per liter. So at this day, we should give maybe like the insulin for the patient on the day 2 rather than waiting for the after the day 5, right? And the second thing is like the way that we are at the insulin in the back, or we should give like intravenous maybe like continuous intravenous insulin. So or we put the insulin in the back. What is the right way? So some there then are not any rule related to this kind of problem. So we can add insulin in the back, or we can use like continuous intravenous insulin for this kind of patient. So this my case related to the parenteral nutrition with diabetes. I hope that you are like getting the point of my case through this slide, and hope that we will discuss more point related to this aspect in the treating process. Thank you.
Thank you, Dr. Nguyen, for your presentation. And this is a very interesting case, and we frequently encounter the Zocor patient in the emergency and the ICU setting. Having said that, it's quite difficult to feed the patient, especially when the patient have multiple polytrauma or multiple organ affected by the trauma or diseases. So now we are going to turn to the audience for question. I got the first question for Dr. Nye from one of our audience. Can you share your experience about nutrition regimen in patient with DKA and HHS? And what is the recommended proportion of glucose regimen? Thank you. Dr. Nye, can you help us answer the question? The nutrition.
Hi. I received the question, and I'm trying to maybe like answer that. Can you share your experience about the nutrition regimen in patient with DK or like HHI and NSS? This quite hard maybe like question, but this kind of patient we have met a lot, especially in the emergency condition. So when the patient like have the DKA or hyperosmolality related to the diabetes, I thought that there will be two maybe like phase related to this kind of maybe like patient. On the first phase, we should maybe like trying to control the blood glucose for this kind of patient on the maybe like initial phase. After the patient meet the criteria for like transfer to the oral nutrition, so we should maybe like add more nutrition, oral nutrition for this kind of patient. It's quite complicated, so I'm not sure that I can maybe like answer it correctly.
Dr. Tao, can you help us answer the question for the audience?
In my opinion, when in the DKA patient, in the first and the most critical steps for both DKA and HHS is aggressive in fluid resuscitation patient. Then control the blood glucose levels with insulin, and then we control electrolytes, especially potassium, and then in the first stage, we can reduce the PN, especially the glucose. Yeah, this is my opinion.
I think this question is have critical merit because we encounter a lot of patients with diabetic ketoacidosis and hyperosmolar hyperglycemic state. So, in my opinion, those conditions usually don't have problem with the feeding, so they can tolerate enteral feeding, and we can start to feed them by nasogastric tube right away. And the question is, the main point in the whole thing in this treatment is that we want to keep the glucose level at the reference range at the preferred range for the DKI and HHS, which is for DKI around like 8 to 11 millimole per liter, and for the HHS around like 14 to 16 millimole per liter. So that's the whole point. Except if they have some problem with the digestive system, and in this case we need to think about other regimen, the kind of like enteral feeding and parenteral feeding. And I just got a other question from our audience. So, Doctor, in your case report, you didn't mention triglyceride. Why do you use nutrition have high lipid amount? So, what do you think about it? Should we need to manage lipid in this case?
Thank you for the question. Maybe like talking about the energy of this patient, I we are lacking of like testing for the triglycerides for the patient, but I thought that the range of maybe like lipid for this kind of patient is in the normal range. Maybe like according to maybe like in my mind, I thought that the range of like lipid for the patient is 1.8 or 2 like not 0.8 to 1.5 gram per kilogram per day. So this patient is like have the weight of 72 kilograms. So we can give the patient like from we can give the lipid for the patient in the range of like maybe like 60 gram of lipid to about like maybe like 100 gram lipid for the patient. So in this regimen, we think that the range the total gram of the lipid is 40 added to like 15 gram of lipid. So in total there will be like 90 gram of lipids. So the range of lipid is in the normal range. I think that is still good enough for this for to you maybe like 90 gram of lipid for this patient.
So yeah, thank you. The amount of lipid or glucose or protein is important, but the infusion rate also important. So if you even give the patient just a more amount of lipid, but you infuse so quickly, so rapidly, it ended up causing hypoglycemia. And one of the side effects of hypoglycemia in patients with TPN is pancreatitis. So we need to watch out of the side of pancreatitis. And actually, in clinical practice, we do see some patients develop pancreatitis after TPN. We don't know why at first, but after one or two cases, we learn our lesson, and that's why we need to be very careful when we infuse the lipid formula, be it in one admixture bag or in the single component bag.
I thought that it will depend on the rate of giving the infusion pump for this for the patient. But if you use in the normal range for like 1.0.8 to 1.5, I think that is not. If we give in the appropriate way, so the rate of complication is being reduced. I think so.
Yeah.
Yeah.
Yeah. If you do it correctly. But if you infuse too quickly, or
Yeah,
if you
right.
not, tell the nurse to do it correctly, and it causes problem down the line. Okay.
Thank you.
Another question. After eating, how did you adjust the nutrition of the patient? How change is your target? The question is probably for the Dr. Tao.
So the target the target of patient um, for protein or energy is depend on the phases of the patient. When at the acute phases in the ICU, so we should provide the maybe 30 or 30 to 50% of energy of a targets of energy of protein, and then after maybe 2 or 3 days we can increase the energy and the target of energy and protein. And it also depends on the how what do the patient weight when it's different between the patient, the malnutrition patient, and the obesity patient. So it's depend on the phrase, the brace. Yeah.
Dr. Thương An Bui raise her hands, right? Do you have any idea related to this question, Dr. Thương An Bui? Maybe for this patient, I want to ask some thought related to the way that we are change in the nutrition for the patient. Because this quite complicated patient. This patient is not have only the problem related to the TBI, but the patient have the problem related to the liver fracture and also the the hemorrhagic bleeding from the intra the abdominal. So the patient have something like bowel obstruction, and on the first day and on this until the third day, the patient is cannot tolerate with like enteral nutrition, and but on the after 4 days, when we give like something like erythromycin or like metoclopramide for the patient, and also giving risk and the injury in the abdominal is being maybe like getting more better, and then the patient can tolerate with the enteral nutrition. So we decided that we should maybe like start the enteral nutrition as soon as possible for this kind of patient. So strategy related to the nutrition is we are trying to maybe like transfer from the parenteral nutrition to the enteral nutrition, maybe like as soon as possible. And then for me, when I read some article, there will be two phase. The first phase is like initial phase. The second phase is we are getting into stable phase, and we increase the maybe like enteral nutrition energy about like 20 or 30% every 2 days. So based on the response of the patient, and after that we can like transfer from the parenteral into enteral for this kind of patient.
Another question is the role of A1C is A1C play any role in insulin decision in your previous case? Nothing yet.
Okay, the rule of like using the insulin for the patient, right?
No, the role of HbA1c, A1C in the insulin nutrition.
I thought that the insulin decision is based on the level of glucose rather than based on the HbA1c, because the HbA1c is referred for the maybe like chronic problem, but the main purpose in here that we are control the temporary hyperglycemia. So if the patient have like hyperglycemia, which is the blood glucose more than 10 millimeter per millimole per liter, so we should like giving the insulin for the patient rather than waiting for the HbA1c. I think so.
Yeah. Okay.